Okay, I think we'll get started. Good afternoon, everybody. Welcome to the lunchtime symposium of Medicontur. I'm Sathish Srinivasan from UK, and I'll be the chairperson for the symposium. We've got a fantastic lineup of international speakers who are going to be exciting, will be sharing a lot of their experiences with a lot of exciting new technologies from Medicontur. So without any further ado, we'll get started. I'm going to be talking on the first presentation, which is on ELON, which is the new extended depth of focus IOL. The idea is to give you some background on the optics and the physics of it, and also the clinical outcomes. These are my financial disclosures. As we all know, that presbyopia correction is almost the Achilles heel of refractive cataract surgery. And as we all know that any presbyopia correction with any of the IOLs in the market, it's a balance of compromise. We are trying to meet what the patient needs with what the patient is willing to accept as the side effects and the compromise. So there is no one size fit all, but the basic principles, we are trying to balance the visual quality with the depth of focus and with the dysphotopsias that can occur with any of these diffractive technologies. But the final concept is to give them good functional vision for distance, intermediate as well as near, with the least amount of compromises. And as I've said before, visual function, you need to, as clinicians, we have to start thinking not just visual quantity, but as a visual function in whole, which is a combination of visual quantity as well as quality. So this is more meaningful way of assessing visual outcome and functions for our patients. In the past, as clinicians, we have been more concentrated just on the quantity of vision, but as more and more of us are using all these newer IOL technologies, we are beginning to understand the quality of vision is as important as quantity. So this is just a snapshot view from the market scope data from last year. The pie chart on the left-hand side shows the global view of consumption of different IOL technologies compared to the pie chart, which is purely European data. As you can see, we have completely moved away just from trifocals, and EDOF, or the extended depth of focus lenses, are beginning to get into the market share and pretty much taking market share, some from trifocal, but predominantly from the monofocal market. So there seems to be a general shift towards using more EDOF lenses purely because of the concept that we reduce the less visual disturbance for the patients and we give better visual quality. So the very contentious issue, currently ISO standards is not available. So this is the ANSI standards, which is the American National Standard Institutes of what is the scientific criteria to call a lens as an EDOF lens. So basically, for at least in the US, if a lens has to be labeled as an EDOF lens, it has to give you at least 0.5 diopters of greater depth of focus compared to a monofocal. The distance corrected intermediate visual acuity at 66 centimeters should be better than a monofocal, and the corrected distance visual acuity should be non-inferior to a monofocal. So till the ISO standards, which is going to be coming towards the end of the year in Europe, this is the current bench standards which we want to look at when we are thinking about EDOF lenses. As you know, the surgical treatment of presbyopia, we started off having monofocal lenses to start with. Then we went to the traditional bifocal, which give only distance and near. Then we realized how much intermediate is important. Then the trifocals came into the market. Now we are trying to redefine ourselves, looking into a new category of lenses called EDOF, which is kind of compromise between the trifocal and the multifocal. And that red arrow which you see, that is where the EDOF gives you that extended 0.5 diopters of good intermediate vision. So once again, different companies use different optical designs to come up with the EDOF technology. At Medicontur, the ELON, we are pretty much looking at elongating the single channel of focus of light, thereby reducing the amount of dysphotopsias. So the ELON lens from Medicontur is a non-diffractive extended depth of focus, and we use a very unique technology which is called wavefront linking. What it basically means is the wavefront linking technology creates an elongated focus of depth without compromising on the quality of vision, thereby giving that not only good distance vision, but also giving good intermediate distances by carefully manipulating the waveform to the chosen concept. So this is kind of the magnified view of what you see on the optic. We have got two refractive zones, and we just play around with the base curvature. And by using linking zones, using wavefront manipulation, we use that one elongated single focus like a monofocal, but we extend the depth of focus using that wavefront linking by linking two refractive zones without offering any diffractive technologies, thereby giving you good quality of vision. So this is how the linking zone works, and this is pretty much at 20 micron width, and that's how you have a good quality of compared to the top. If you look at the bottom, these are all optical bench testing with a very sophisticated software. That's that elongated focus field of vision gives you the good distance and a good intermediate. So this is the lens. This is a patient of mine. I'm just showing you the intraoperative view. It comes in a very specialized, unique single-use cartridge where you've got two different compartments where you inject OVD to prime the lens, and it goes through a 2 millimeter self-sealing clear corneal incision. And that's the lens. It's a single piece, hydrophobic, with a very stable biflex platform, giving you very good stability. And there you can see those two pretty much rings, but these are not diffractive rings like we are used to with trifocal lenses, but these are rather two refractive zones which are being linked by the wavefront. Once again, using that coaxial illumination, you can see that rings are very nicely centered on the patient's visual axis. Can we just move on to the next slide, please? I'm able. Okay, that's better. So I'm just going to share with my experience of, we have done more than 50 eyes, but I'm just giving you the initial data. These are 32 eyes of 60 patients. So just walk up with me, you're going to follow a pattern. These are monocular uncorrected distance visual acuities at month 1, and all the graphs which you're going to see on your right-hand side are binocular visions. So the green one is uncorrected distance, the middle one is uncorrected intermediate at 66 centimeters, and the last blue bar is uncorrected near. Well, these are 1 month data, both monocular and binocular. And if you start seeing the patterns, whenever you have bilateral implantation, you can see that bilateral cortical summation helps, and you have improvement in the uncorrected distance, intermediate, and near. So this is month 1. This is month 3. Once again, monocular on your left, binocular on your right. And I've shown you what these each colors look for. So that is month 3, and this is month 6 post-op, and this is 12 months. So you can see by then almost the cortical, the brain's cortex has got used to this, and if you had followed the graph, you would see as we prolong the follow-up period, the uncorrected distance, uncorrected intermediate, and surprisingly uncorrected near vision visual acuities improve as well. Once again, these are all just with Elon. At this point of the study, we didn't have Elon toric, but as of last week, I've implanted the world's first Elon toric intraocular lenses. These are patients who had the non-toric version, but we have very carefully selected with preoperative corneal astigmatism of less than 0.75 diopters. Once again, shows you if your patient selection is very accurate, and if you concentrate on your surgically induced astigmatism, these results are very, very good. And especially with bilateral implantation of the Elon, as the brain gets used to this, patients, all vision in all distances seems to continuously improve. So that is all the vision. These are data of post-operative refraction. Once again, month 1, month 3, and then month 6 and month 12. Once again, we will show how tight the standard deviation is. We spend a lot of time on patient pre-selection, keratometry, and IOL power calculation, choosing the best state-of-the-art fourth generation formulas. And once again, you can see how tight both the spherical and the spherical equivalent is at 6 months and at 12 months. And this is where the rubber meets the road. This is the defocus curves. Once again, showing that this is all in logmar. So 0.0 is 1.0 in decimal, if you like that language. And you can see what happens to the defocus curve at 67 centimeters. This is uncorrected intermediate visual acuity. And you can see patients are getting almost up to 1.5 diopters of depth of field of focus. That blue bar is binocular vision, and the green bar is monocular. Once again, you can see bilateral implantation of these kind of technologies raises the bar because of the cortical summation. Patient have a bonus added effect of improvement of their vision at all distances, distance, intermediate, and near. And once again, I'm going to bore you with this, but this is the VFQ-25 questionnaire as part of these studies. Patients, all these patients had a VFQ-25 questionnaire, which assesses the quality of vision. So you can see all these questions on the left-hand side. Once again, they give you a very high score. 1 is no difficulties for most of the day-to-day activities, and number 5 is they have stopped doing something. So you can see the scores of between 1 and 2 is very, very good. So they are happy with their driving, they are happy with able to do all their activities, and they're generally the vision is good. So the quality of vision, what the patients experience is very, very good. Once again, bilateral implantation does better than unilateral implantation. So to conclusion, I think ELON IOL is a safe and efficient option for treating both not only cataract, refractive cataracts, but also as a solution for presbyopia. Intermediate visual acuities are excellent, and always with EDOF technology, we always under-promise to our patients, telling they would require glasses for reading. But it's very surprising to see that at 12 months follow-up, patient's brain is able to adapt, and even their uncorrected near vision acuities, which we don't promise, but seems to be better than at least what I expected. Patients' subjective standardized VFQ-25 standard questionnaires shows that patients are very, very satisfied with their day-to-day activities, and their dependency on glasses is very, very less. So just to pitch you, next year, we have the big UK meeting of the UK Cataract and Refractive Surgery Society, and this is the big year. This is the 75th anniversary of when Professor Harold Ridley invented IOLs. So please mark it on your calendar. We would all welcome you. It's going to be a huge international event with great representation from all over the globe. Thank you for your attention. I think we'll take questions all the end. I'll be delighted to, thank you. So next speaker is a good friend and colleague of mine, Owen Kruger from Cape Town, South Africa, to come and share his experience. Owen?
I'm delighted to be here at this meeting and to speak to you about matching the IOL to the patient. These are my financial disclosures. So patients nowadays have raised expectations when they come to us for vision correction, and people would like a spectacle-free lifestyle. So there are quite a lot of considerations in this. So what is this matching concept? We have to look at patient-specific ocular characteristics. That's very important, and match the patient or the IOL to the patient according to that. Because all our EDOF lenses and our multifocal lenses and trifocal lenses are different, and you have to understand which lens you will use in which patient. Not every lens will suit every patient. And then we need to also look at patient-centered considerations, and you look at the visual goals particularly, so you have to spend some time to get to know the patient to actually decide which lens will suit the patient. And this is a type of a holistic approach to the patient. So during the consultation, we interview them on their hobbies, their sport, their families. We do a dry eye questionnaire. And you particularly have to find out which is the working distance, and in the daily life, what will the patient require. And we always test the eye dominance first, which is the dominant eye, because I also find that this is important. Do a full eye examination to make sure there's no other comorbidities. Pupillometry and habitual refraction, and this does take a bit more chair time, of course. We need to do certain special investigations, and I will not go through all of them, but these are the ones that we do on all our patients. We look at the quality of the vision we can expect from the cornea, higher order aberrations, the epithelium, which is important, and the astigmatism. And we also look at the angle kappa and the angle alpha. As you can see on the left, on this side, you will see that this particular patient will not be suitable for a trifocal lens. And on the other side, that patient would be suitable for a trifocal lens. So that's very important to do that. Sometimes the eyes differ. The one eye will be suitable and the other eye not. So there's various options to treat presbyopia. We can do a monofocal type of a monovision or blended vision type of approach, or we can do a micro monovision where we put a EDOF in the dominant eye, aim for 0, and in the non-dominant eye, we aim for minus 0.75. And then there's this custom match or mix and match. I call it custom match, where you can put in the one eye an EDOF lens, and in the other eye you can put in a multifocal lens like the Liberty lens. And then you can use the trifocal in both eyes if the patient is suitable and if the eye is suitable. And I think it's important to, when you discuss with the patients, to explain to them the concept of a full range vision IOL or solution, or an intermediate range vision IOL, instead of saying EDOF. They don't know what EDOF means. And when you tell them about a trifocal, they say, no, the glasses are not working for me. You know, so speak on these concepts is more understandable for the patient. So the custom match concept I started with this already in the 90s, where I was combining various lenses. And my first one was the distant dominant array lens, which didn't have very good near vision, and the Storch True Vista lens in those days, which was a typical bifocal lens. And I mixed the two up, and I published it in these books in those days and in various articles. And up until today, I still see some of these patients come in and they're totally spectacle-free. So the aim really with the custom match is to give a full range of vision to the patient, to limit your dysphotopsia, and the patient still has a full range of vision. So in my approach, I'm currently using the Elon as the EDOF. It's a non-diffractive, as we all know, and we heard a beautiful talk now by Sathish on how it works, so I won't spend time on that. And also the trifocal lens, the Liberty, I put in the non-dominant eye. And this lens, because it has less rings, it also has less halos. So, looking at my results, we've really had excellent results. As you can see, a large percentage of patients, 20/20 vision uncorrected, and 20/25, almost 100% of these patients. And then the uncorrected intermediate vision was equally good. Most of the patients were, well, all of them were better than 20/40 at least. And then the uncorrected near vision was also, we had 100% 20/30 vision at near. And also 100% was within one line of the corrected distance visual acuity. And the spherical equivalent range was also a narrow group. And the post-operative refractive cylinder was also very good. Most of the patients were less than 0.75. So looking at the contrast sensitivity curves, these are 11 bilateral patients. So you can see the contrast sensitivity curve on the top there. And then the visual acuity curve, defocus curve was also very good. And then the contrast sensitivity for 1 month, 3 months, and 6 months was almost a straight line. And the visual acuity was also excellent, as you can see. So I'm quite enthusiastic about this approach. And this is an important slide as well. As you can see that the patients are happy. There's only a small percentage of patients that actually reported dysphotopsia. And very few people were not able to do all these daily tasks. So in conclusion, I found less dysphotopsia, less complaints, happier patients, very good near VA, and only 5% reported minor difficulties, and good intermediate vision. Thank you for your attention. Next speaker is Alison.
Thank you. It's a pleasure to be here all the way from Australia. I'm going to present a very small case series of unique applications of add-on IOLs. These are my financial disclosures, and I will move through with lightning speed. So some of the applications that we can use the add-on IOL is as a single dual lens procedure, so the 2 lenses at the time of surgery. For the patient or the surgeon who's not sure about multifocality, allowing a reversible option. We can also use the toric version when there's the possibility of astigmatic change over time. The add-on IOL can be used as a secondary delayed procedure for the patient that wants a trifocal or toric upgrade, for the weird corneas, so keratoconus, marginal pellucid degeneration, corneal scarring, for example, where the axis and or magnitude of astigmatism may not make sense from preoperative keratometry and is inconsistent. And as a novel use, as for protection of an in-the-bag hydrophilic IOL from calcification if you need to do a DSEC. So these lenses are very easy to use. This is a dual case. I've implanted a toric in the bag and vacuumed out the viscoelastic and then put viscoelastic into the sulcus to implant. The underlying IOL, which is a double C-loop haptic, a Medicontur lens, is very rotationally stable, even though I'm having to manipulate this add-on lens a little bit just to get it in the sulcus, and it's very easy to vacuum out the viscoelastic from behind the IOL, from the add-on. Our options are trifocal or monofocal toric or non-toric, and then of course the Cherioth macular lens, which is the high near ad for your dry stable AMD patients. Laser is not always the solution. So we all have dissatisfied patients with dry eye ocular surface disease. Laser is not reversible. Some patients are not suitable. And for some surgeons, they may face issues with laser suite access. The first case I would like to present is a 72-year-old male with best corrected vision of 6/21 both eyes, with cataract, slit lamp, otherwise shows a healthy exam, and quite a degree of astigmatism in his glasses and a little bit inconsistent on the autorefraction. This is his tomography. It shows an abnormal cornea suggestive of marginal pellucid degeneration. So which SIL would we correct when the keratometry from the IOL master and the pentacam is so inconsistent? And it's not that we would use the subjective refraction to determine, but the subjective refraction can give us a clue as to what component is irregular compared to regular and correctable versus irregular, if we can have historical records and see how good the best corrected vision has been. I performed a 2-stepped approach. I did a right primary cataract surgery with the monofocal non-toric in the bag, aiming for emetropia. Taking the rule of 2s with 2 stable refractions more than 2 weeks apart, usually after the 4-week mark, obtained a stable refraction here and implanted a toric add-on IOL to correct the residual refractive error with a good result of 6/6 and minimal residual refractive error at the end. Case 2 is a patient, 68 years old, with previous high PRK myopic correction with resultant extensive corneal scarring and high myopic regression, with a concurrent macular schisis managed by VR surgeon with best corrected vision of 6/21 and cataracts. The subjective refraction is different to the glasses prescription, and we decided after discussion to target low myopia for this patient with a monofocal in the bag. And you can see from the orb scan at the time that the cornea is very thin and very flat, consistent with the previous myopic correction and also corneal scarring. So when we look at the keratometry, we can see in the right eye that there's not a lot of astigmatism, but the axis does vary a lot. In the left eye in particular, there's a large variance in the axis and the magnitude of astigmatism. So in the left eye, I performed a two-stepped approach. This cornea was slow to recover, as was to be expected, and took some time to get a stable correction. This patient also came from interstate, so she was travelling 3 hours to come to the clinic for her visits. But we obtained a stable refraction and used a first Q add-on IOL to correct the residual astigmatism. Again, post-operatively, because of her cornea, it did take some time to settle, but she ended up with a very good result given the extensive corneal scarring that she had and better vision that she had had for a long time. Case 3 is a 72-year-old male who was referred for a second opinion after a couple of surgeries, had a right macular hole repair, right extensive nasal pterygium excision with autoconjunctival graft, which resulted in corneal scarring, and then had cataract surgery and was referred for reduced vision in the right eye following cataract surgery. And this was what he was wearing in his glasses. And his subjective refraction showed even more astigmatism than what he was wearing of 8 diopters. The current lens that was in the bag was a T9, so 6 diopter lens, and it was sitting at 115 degrees. We had no information about where it should be sitting. And the topography shows some regular as well as irregular components to the astigmatism. The keratometry from the IOL master and the pentacam were quite inconsistent, also not consistent with the subjective refraction. And we did not know where this lens was supposed to be sitting. So looking at the options, corneal refractive surgery was not going to be the best option for this patient. We could do an IOL exchange, but what power and axis of IOL were we going to replace with a toric IOL that was already in the bag? And that placed higher risk on the patient to have a lens exchange. Repositioning that current toric IOL of 6 diopters was not going to resolve this patient's residual refractive error of 8 diopters of astigmatism. So we used a first Q add-on to correct the residual refractive error and large amount of anisometropia that was also problematic for the patient. So that was an 11 diopter SIL toric add-on IOL. They come in very wide ranges of power with a reasonably good result given the patient's other ocular comorbidities. The patient was then referred back to the original physician. The last and final case I'd like to present is the use of a sacrificial add-on IOL in the case of a patient needing a redo DSEC. So back in 2011, had cataract and DSEC with a good result. Zeiss hydrophilic lens was placed in the bag at the time. Patient then presented more recently with vision reduced down to hand movements due to a decompensated DSEC. And we were concerned about calcification of the hydrophilic IOL in the bag, so implanted a plano add-on IOL to protect that hydrophilic IOL in the bag. And to date, that patient is doing well. There has not been any issues with the add-on IOL, so it has not needed to be explanted, but could be down the track if the need arose. So just one of the points with these IOLs is they're loaded through a Medicell injector, which we're all familiar with. They're very easy to load. You just have to take very careful attention to positioning the 4 haptics underneath the flange and make sure that the lens does not buckle upwards as you close the injector. And the final point that I would like to make is many people in this room would not know, but I am one of 2 sets of twins, so sometimes 2 might be better than 1. Thank you.
Next speaker is Joaquín Fernández MD. He's going to be sharing his data on quality of vision with
Thank you very much, Sathish. Well, the idea is to present to you the performance of the ELON-EDOF lenses in the real world and in the long term. All of us, we know that the clinical trials are in the high level of the hierarchy of the evidence because control absolutely well the bias that could happen in other studies. But sometimes the criteria of exclusion is so demanding that it's not compared with the real world. So our concern was what could happen with our patient in the real world, that normal patient that we have in our clinic. This is the aim outcomes of this presentation. This is our disclosure. We are consultant on Medicontur, and this could affect to this presentation. You need to know. This is the sample characteristics. The follow-up was at the beginning 3 months, but look at that, a very older patient, not as young that we can see in some sample of clinical trials, and we have some morbidities in some patients. You can see here one patient operated of myopia, one monocular, 20 binocular, but even patient with ocular history from glaucoma, one patient with a retinal detachment after the surgery without any risk but happened, and we don't exclude these outcomes. And the follow-up at the beginning was 3 months, then we complete to 1 year. It's very interesting to see the efficacy. You have here at the left the cumulative percentage of eyes for the far distant in monocular, but it's very interesting to know exactly the vision corrected by distance, because talk about the lens, not about the efficacy of our prediction for the biometry. So let's go to see the corrected distance visual acuity in monocular is around 0 logbar, 20/20. In intermediate, we have a mean in monocular of 0.16, and in near, you have a visual acuity corrected of 0.33. So the idea is let's compare with some other lenses that we know of this family, the EDOF refractive lenses. We share with you, you can acquire this application, is the EOL evidence you have in the Apple Store. We develop this application in order to collect all the data, all the studies that have been published with all the families of the lenses. So let's go to the family EDOF, refractive, and let's go, for example, with a very known intraocular EDOF lens like BBT. So we can see here that the medium of all the study is quite similar to the outcome that we could have with ELON in distant and intermediate and in near, as you can see here. So let's go to the efficacy in terms of binocularity. Well, as you can see, the distant corrected is for distant almost 0. In intermediate is very high, 0.1, and for near, as you can see, for 40 centimeters is 0.24. Again, is quite similar that we can find in literature comparing with this family, exactly with the wavefront linking or the wavefront shaping, this new family that we have in the EDOF refractive lens. So let's go to the focus curve, the monocular defocus curve. At the left in visual acuity, at the right, the contrast sensitivity. As you can see, it doesn't have a monotonal the decrease of the defocus curve. And when we compare the visual acuity in monocular with binocular, you can see that it's improved almost one line and very continuous in all the type of focus. Let's go to very interesting thing. Let's compare, because when we talk with other doctors that implant EDOF refractive lens, whatever you want, sometimes this doctor, your guys, your colleagues, tell sometimes the behavior is incredible, fine, but in other it happened. That's incredible outcomes. Well, let's try to identify some biometric parameters that could affect to the performance. And we compare the area under the curve and intermediate, all of the focus curve in the intermediate, and we compare with the photopic pupil diameter, you can see a correlation. When we have bigger pupil, we are going to have a decrease of the area under the curve. But this is not for the ELON, it's for all the EDOF refractive lenses, and probably you need to know. In very young people with a very big pupil, probably is not a good option for that. What could be another problem with this family of lenses? This outlier that you are seeing here is because of sun decentration. So this could be these two. We only have these two outliers. The other three was a fall in the capsule. But it's important to know that a little decentration, comparison with Liberty, for example, is diffractive, is going to affect more, and the big pupil is going to affect more. Let's go to the patient-reported outcomes of these 21 patients, and we also include the patient-reported outcome of the patient that developed the retina detachment. But you can see here the satisfaction with the vision. The green and the yellow color are good news. The orange and the red are bad news. We have the satisfaction in a very high level of category, almost in all the people. Look at that, the retinal detachment, of course, is not happy with the operation. And it's very interesting also, the bothersome with a positive dysphotopsia, it has an excellent outcomes with this type of lens. And almost everybody, likely same procedure would be made if we repeat. We asked them after 1 year, and it's very interesting, after 1 year, the outcome, the patient-reported outcome, getting better. It's very interesting that getting better overall in the positive dysphotopsia. So in some, we are going to some amount of neuroadaptation that is going to improve the satisfaction of our patient. Overall, it's very interesting that even that complete spectacular independence is not as high of Liberty. I'm absolutely supporter of Liberty trifocal lens, but the satisfaction is high for this patient. So finally, as conclusion, we have to know that 𝐿-𝐷 feel like PBT with comparable outcomes. With other EDOF refractive lenses, the results are more variable than with Liberty lens. As we know, this family is affected by the decentration at the big pupil. It's not only 𝐿, occurs in all the family, with BBT also. This variability is explained mainly by the pupil diameter, and a smaller pupil, patient that you are going to have with a smaller pupil is the best option for this type of lenses. And the answer of the satisfaction, positive dysphotopsia, and the likely to be implanted with the same intraocular lens improved from 3 months to 12 months. It's very interesting to have this, trust, this confidence that the neuroadaptation is going to improve an excellent outcomes if you explain adequately to your patient to an extremely excellent outcome. So thank you very much for your attention.
Thank you, Joaquín. I think I'm very impressed that so far we are all sticking to the time, which means we'll have some time for discussion. The next speaker is Dr. Cervantes-Coste from Mexico. She's going to be speaking on the impact of lens desaturation and visual disturbance.
Thank you, Sathish. Good afternoon. It is my pleasure to be here talking about these visual disturbances and the decentration of presbyopia-correcting lenses. I do not have any financial interest in these lenses. When we wanted to know who was the optimal candidate to implant this kind of diffractive trifocals, we did study the intraocular lens decentration and also the dysphotopsia using the Polit method for decentration. Our study design was composed of 73 lenses. We studied Liberty, Panoptix, and Atelisa, and these were some of the parameters that we studied: visual acuity at distance, intermediate, and near. The visual functions, we apply one of the questionnaires that is called 𝐏𝐿-9SF, 9SF, the area under the curve, the dysphotopsias, the intraocular lens decentration, and also the white-to-white anterior chamber dead, among others. We wanted to know if there was any correlation between these parameters. I have to tell you that the preoperative characteristic of these 3 platforms were almost the same before doing the study. When we look at the investigating intraocular lens Liberty, Atelisa 3, and Panoptix, I would like you to see the number of rings and the size of the central ring. And we know that we should not exceed half of the size of the central ring if we want to avoid dysphotopsia. So that's an important point to remember. When we look at the focus curve, they were very similar in the three platforms. As you can see, all of them look very, very similar. And studying dysphotopsia, we know that dysphotopsia is a main concern for patients, but also for us as cataract surgeons. So we did study the frequency, the intensity, and the discomfort, and we studied the glare, the halos, and the ghosting. And we know that the smaller the triangle, the better the result. So as you can see in the three graphics, we could see which one way are better lens. This was one of the results of the questionnaire. We took true examples, and as you can see, 85% of the patients did not have any difficulties in visual function. So I'm just showing you one of the activities at far distance that was seeing subtitles on the TV, and the near vision was like seeing prices on price tags. And 85% of the patients have no difficulties or just a little bit of difficulties. This is the centration. This is the way we measure the centration. It was 3 slides. It was center, 0, slide number 1, and moderate number 2. And as you could see in the graphic, most of the decentration was present in the panoptic area, and 87% of the panoptic lenses were the center, even that, however, they stayed 13% of them, they stayed center, they were more prone to move temporal. The direction of the decentration was more temporal in 66% of the patients. And Liberty and Atelisa did not have a characteristic direction of the decentration, and the amount of decentration was smaller than with the panoptics one. When we look at the visual acuity with the focus curve, the centration has a remarkable negative impact on the visual outcomes. We were suspecting that, and we could measure that. So if you look at the total area under the curve, the best lenses were, of course, the ones that were rather center. They were the happiest patients, followed by the temporal decentration, and finally was the nasal decentration. And we know that nasal decentration has a very detrimental effect than temporal. So we should find a way to avoid the nasal decentration of trifocals. When we compare anterior chamber depth with decentration, there was not a significant result, so we couldn't make any really comparison of this. And when we measure white to white with decentration, there was not also a significant correlation between these two results. But when we look at the examining parameters with decentration, like the intraocular lens power, the intraocular lens thickness, the axial length, the amount of sphere or the amount of cylinder, there was not an equivocal correlation could be found between these parameters. And even that we know that axial length and anterior chamber depth have some role in the decentration, with this data that we examined in 73 patients, we could improve that. So maybe we just need further data to show that. So in conclusion, with dysphotopsia, all patients manifest some dysphotopsia, and maybe we believe it is because of the diffractive optics. The lowest frequency and intensity of dysphotopsia was with the Liberty lenses, and the more discomfort was reported with the Atelisa 3. In terms of intraocular lens decentration, the biggest decentration, as I told you, was with the Panoptics platform, and they have more like a temporal direction of decentration. Liberty and Atelisa didn't have a typical direction, and they had a small amount of decentration comparing the three platforms. Both temporal and nasal decentration, we know they do have affection of the visual outcomes at multiple distances, intermediate, near, and far, but nasal decentration is the one we have to avoid because it has the most negative effect. Talking about anatomical measures, we know that intraocular characteristics did not have any impact on the decentration as we were expecting, but maybe we just need to study much more lenses to see that, or more extreme eyes, because our eyes were like normal range eyes. So that's why we expect these results. Diffractive intraocular lenses need to be centered. That's very important for us to know that if you cannot predict the centration, we will always have some decentration, and that will affect the visual outcomes. So this is a big thing that we have to work on, how to avoid decentration with all these multifocal lenses. Thank you very much for your attention.
Thank you, Guadalupe. The last but not the least, a great pleasure in introducing Dr. Gunnar Gundersen from Norway. He's going to be speaking on the FirstQ add-on.
Dear colleagues, I want to share with you my experience with the FirstQ add-on lenses, which I personally mean is a very effective way and flexible way to treat presbyopia. These are my financial disclosures. And I have worked with treating presbyopia for more than 20 years, implanting several types of intraocular lenses. And to sum up this experience, I think the second point here is very important. You need to be brutally honest, communicated both the downsides and the positive sides with every single lens, because there are no perfect lenses on the market yet. And if you practice that, you'll have less dissatisfied patients for sure. This is all the platforms for presbyopia treatment with the add-ons. You have already heard that. And I'll just show you 5 publications that we have performed between 2016 and up to 2022 using these lenses in different scenarios. But I will come back to them more specifically. This was a study where we treated rest refractive error. So the blue bars are the post-cataract refractive status, and the brown bars are the status after add-on implantation. So no hypertonia or hypotonia after performing this procedure, no interlenticular opacification, and no iris shafting with subsequent pigment dispersion. So it's a very, it's lenses which is nice to handle, and they behave well. Looking at the toric stability, most of these eyes, 18 eyes, didn't move more than plus minus 5 degrees, and a few of them up to 10. But comparing this with the main competitor, which I started out with add-ons, the Sulcoflex, rotated up to 62%. So actually, when I go historically back to starting with add-on, it was the need to have a stable lens to treat toricity that really encouraged me to go into this business and make appointment with Thomas and his gang. So the next one is the EDOF, which we have seen and presented. And I want you to pay some attention to the flatness of this curve. Although it's an EDOF, you see it has a wide range of optical performance and no dip. If you see the next one, which is then the trifocal, it's a more traditional two heights. And it really, I haven't studied it in detail, but if you combine these two lenses, that should be a very nice option. So 2 of my colleagues have published on using add-ons in a 2-step or a 2-lens systems. It's Alfat Koramnia from Heidelberg and Harrisburg from Australia. And to sum up their papers, the one from Heidelberg can actually say that 2 lens combinations perform optically as good or better than 1 lens. And if we look at the clinical performance performed by the study by Harrisburg, the 2 lens combinations perform clinically as good as or better than 1 lens. So there are no difference. Either it's equally good or potentially better. Some surgical tips after more than 5 years of experience. I would really highlight using a 2.75 incision. This is a cold incision without any phaco procedure, and it doesn't affect astigmatism. Then you have more room and more space to work with. Optimized pupil dilatation, of course. Visco over and under the iris at 4 position where you plan to have the 4 haptics. And I would recommend, on contrary to my colleague, to load this lens convexly with the back up. And that is based on the experience that if you do so, it will dive into the correct position with the 2 leading haptics. And if you retract and push down, it will, with some practice, you will have all haptics behind the iris in one procedure. So careful removal of all visco, and I remember what you, Sathish, said some years ago. If you fail to remove viscoelastics between the 2 lenses, you might end up in serious trouble. And then ordinary zero drops after surgery. And this is the situation if you look at it with the OCT and the model. You have a nice distance between the primary lens and the add-on lens, which is stable. And that's probably the reason why you don't get any interlenticular opalsification with this combination. So my closing remarks would be the sulcus fixating FRCSEd add-on is easy to implant and explant. Refractive predictability and stability are excellent. Both the EDOF and the trifocal deliver excellent glass independency, and they might also be combined. Both primary and secondary add-on presbyopia treatment represent a huge patient potential. Just bear in mind all the monofocal patients out there which might want to have a presbyopia treatment. And safety and efficacy is excellent. Thank you.
Thank you, Dr. Gundersen. I think we have got 10 minutes left, so we'll open up the questions for the audience. Please feel free. There are some standing mics here. If there are any questions, feel free to come and ask and use the expertise of all the panels. Any questions? Okay. I will start off with a few. Oh, there you are.
A question to Dr. Cervantes. Do you think that in the study, the thing that in Mexico you don't have toric liberty IOLs impacting the quality of vision in this study?
I'm sure it did. You know, by the time we did the study, we didn't have the toric platform. So if you see, even though our results were 85% good ones, but we took the patients that were like one diopter or 1.25, and we tried to go the incision in the sharpest meridian. So I'm sure now with the toric platform, the results are going to improve for sure.
Thank you.
Any other questions? Yeah.
Dr. Kruger and Gunnarsson, have you noticed ever any complaints about in patients who had the mix and match lens implantation, if they noticed any disturbance in the one eye and not in the fellow eye?
No, well, the first important thing is that we're doing, bilateral sequential cataract surgery. So you either do both eyes on the same day, or what I'm doing is I'm implanting the Liberty in the non-dominant eye on the Tuesday, and on the Thursday I'm implanting the Elon lens. And I've got a theory, and I hope I can prove it sometime, and that is that the non-dominant eye is actually ignoring the dysphotopsia because of the dominance of the non-diffractive EDOF lens. The patient is not complaining, or you ask them about the dysphotopsia, and They don't know really what you're talking about in most cases.
Even in longer terms of follow-up, that's what you not forget.
Say again?
In longer terms,
Yes.
you have observed
So,
something.
most of these patients are almost a year, and some of them are even post a year.
Yep, thank you.
Sorry, I have another question for Joaquin. So in the ELON IOL, do you think we have to search for some corneal aberrations previous for using this technology, or we can be more easygoing for this type of IOLs?
We really don't know right now. For example, we report that the Maeda cutoff of irregular astigmatism, aorta aberration higher than 0.5, could dramatically affect to the performance of the trifocal diffractive lens. Right now, I didn't read anything in the literature, but it's very interesting, at least to see if we could improve or reduce relationship with the spherical aberration of the patient, overall in patient operated by refractive laser correction. It would be interesting, but I didn't read anything in relationship with that.
Just a question for the last speaker, and I was a little bit surprised. You wrote also easy to explant the. What was the indications to explant the add-on lenses, and how you do explant? You put it in the anterior chamber, you cut it, and you take it in 2 pieces out?
The indications for explantation would be if presbyopia treatment were not tolerated. Up till now, this indication hasn't been performed in my clinic. One other is that you end up with the wrong refraction, and it's easy to mobilize from the sulcus. You can extract it in one piece through a 2.75 millimeter diameter. You don't need to cut it. So if you have the correct instrumentation, it's really easy to handle. And you can also think about that if things changes over time, and our eye is not a piece of plastic, it's a living tissue. You might also be able to change that refraction over time if needed.
Okay, thank you.
Any more questions? Any questions from the panel? Okay, I think we'll call this a close. I think we've got finished 2 minutes before. Thank you all for coming. Hope you find it useful. Enjoy the rest of ESCRS and enjoy Vienna. Have a good day.